More than an issue, it is the number one barrier to learning. So when you come to this book, your number one barrier to learning is you're uncomfortable because no one else is doing it, and everyone else is doing first aid and some multiple choice question bank. And I'm telling you, don't. Well, that's a really big swallow, isn't it? So
Yes, it
I
is.
never win the students over until about the fourth or fifth time, and they go to their multiple choice question bank and they go, this makes perfect sense. It wasn't just, can I find the magic word that lets me link to an answer? No, it's a conversation.
Dr. Tisdall, we got a great comment from one of your followers this past week. They're loving the content, but they're asking some really thoughtful questions about how you teach and what your methodology is and how you think. So, the first question they asked is they say they're planning to purchase the book, but they'd love a quick tour of how a chapter of the book on any particular disease is built, understanding what you were thinking as you structured it.
The book, I hate to call it a textbook. I really do, because we all bring a connotation to textbooks. We've all suffered with them through school. They're all very stylized. You never feel the book was written for you. You always feel that the book was written for other people of equal expertise and you get to participate. So that isn't what I wrote. What I wrote is a book that came out of my teaching notes. And it goes all the way back to the original Robbins textbook of pathology, in which he was actually a Toronto pathologist who did a million autopsies, and he got tired of repeating himself. So he just wrote his lectures out and called it a book. Well, that's what this is. This is a teaching book. It is how, if you were with me in person, I would teach the subject. And one of the things that has delighted me, I didn't expect it, is it turns out if it's a learning book, it's a teacher's book too, because now you know what you should be teaching your learners. So this is how it was set up. It is set up specifically for you to learn from. And it starts with the first 13 chapters are the basic principles. Like if you do acute inflammation, every organ system we go through is going to have an acute inflammatory disease. So they all have, after a while you say, well, I'd like to know more about acute inflammation as a subject. So, I had to put it at the front because that's traditional and it was too radical, I think, for most people. But it should have gone at the end. After you've looked at all your diseases, well, I'm kind of interested in how autoimmune lymphocytes work, as opposed to the autoimmune disease in the thyroid. Okay, so the first thing are the principles universal to all these diseases. And then we start systems. So heart, lung, circulatory, kidney, just like you'd expect. And they all start, every system starts the same way. It starts with clinical, pathologic correlation. And that's actually a really specific, really old, ancient term that has fallen out of use when we stopped doing autopsies. And what the term comes from is back in the day, and I'm old enough, this is before there were CT scans, people literally didn't know what was going on inside of their patient. And so when I first started practicing, half of all hospital deaths would have autopsies. And so I'd come in, as a working pathologist, I'd look at the death board and I'd say, okay, so here's poor Mrs. Smith, she's getting an autopsy. And I'd call surgery and medicine and say to them, when are you free? And we'd come down and there's a patient they'd known for years, but they'd never quite understood, what was I feeling in the right lower quadrant? Well, I thought the fever was arising from this, was it? And so we would specifically take the clinical question and correlate it to the pathology of the patient. And I would bet, let me be fair here, I'll bet 2/3 of autopsies had a significant pathologic finding that would have altered the treatment if they had known. It became such a profound quality control tool that we would then present autopsy findings to the whole medical staff. And slangily, of course, we called it death rounds, but it was called mortality and morbidity rounds. And it was the foundation of medicine. Well, fast forward, we got MRIs, we got CTs, we got fantastic blood work, endoscopy out the wazoo. Yeah, there stopped being surprises. By the end of my career, everybody died with pulmonary embolism and bronchopneumonia. Well, sure. When you're spending it's the last 10 days of life, you're just lying still in a bed.
I thought it was
So
a
what
reference
happens
to
when
the
you
fact
lie
that
still in? No. When you lie still in a bed, right? It's a risk factor for coagulation, and you don't clear your pulmonary secretions. So you see all these fake reports going, oh, pathologies are still useful. Okay, take out the bronchopneumonias and take out the small pulmonary embolia. What are you left with? Yeah. So, we stopped doing autopsies about the time hepatitis B became a big deal and then AIDS came in. Well, you had to have a level 4 viral procedure to do them, and we just stopped. So, clinical pathologic correlation is a time-honored term, and I'm bringing it back because I don't want to teach pathology. I want to teach clinical pathology. That's why the book is Clinical Pathophysiology. And what it starts with is the patient. And the patient has symptoms. That's where everything has to start. And this is why it's so hard to teach yourself medicine, because every one of those symptoms requires a different approach. So every chapter on every system starts with clinical pathologic correlation, and then out of necessity, you've heard me rant about this before, the next chapter is structure function, because people are not taught their anatomy in a way that I can use it in clinical care. A simple example, heart. Everything in heart is the echo. There's a very funny medical comedian, and whenever he does the cardiologist, the patient will present the case to him, and then he'll look at them and say, so what'd the echo show? No matter what happens, right? Fell off a curb. Yeah, right. So what'd the echo show? So could you imagine not having the anatomy, the short axis, long axis view as a way of thinking about heart when that's how all practicing cardiologists do? So it turns out I have to go back. And, it's really shocking when you have students that have not been taught clinically. You think that's fine. I'm just going to show you the short axis, long axis of the heart, okay? Well, here's what they've never been asked to do. They've never been asked to say, okay, so here's your heart. What would it look like if I just cut it end on? That's a short axis view. Can you see that? What if I said, here's a long axis view. I'm just going to look in the inside. Can you do that? Well, it turns out I'm teaching how to rotate objects three-dimensionally in the brain. Because if no one's done it for you, you're just looking at a picture. No, you got to see the heart and move it in your brain, because that's what echo does. So then I have to do structure function. Version 2.0 of the book's coming out in a sec. And, there's a few pretty profound changes. One of the changes is going to be in the structure function of GI, because I actually had to teach a GI physiology course because the PhD left and here we were. So I had to quickly deepen my knowledge. Yeah, I couldn't trust the GI physiology they had. When I was teaching GI physiology, their anatomy hadn't prepared them for how to think about it. Okay, well, I made a bad assumption in version 1.0 that they had GI physiology. Now that I've taught it, that's a big expanded chapter. So structure function isn't just a quick review of, no, it's how do you think about this organ when I have to use the clinical way of thinking about it? Some organs, you got to have histology. I just can't do the kidney if you don't have the nephron. I just can't. So you got to back and make sure, so did your anatomy, histology, physiology give you what you need in a clinical explanation? And then after that, each subject is not treated equally. So here's where this is not a textbook. Everything is 80-20. I'm only going to teach you 80%. That's all anyone carries in their head. If you want to learn all the rare things, go look them up. I'm not doing that.
How do you decide what not to include, the 20%?
You ready for this?
Yeah.
Because this is a highly personalized textbook of someone who practiced 40 years and is taught for over a decade. If anyone else wants to come in and say they include it, happy to have the discussion. It is agony. Because someone for sure is going to say, oh, here it is in first aid. Yep, you're right. It's in first aid, and I'm not going to teach the porphyrias. Not going to do it. So, I've got a very worrying moment coming up in the medical school I'm in, because we're going into the heart unit, and the unit head is a pharmacologist. And I would bet 25% of the teaching is pharmacology. So they're going to have a whole week on the pharmacology of heart drugs and 1 day on congestive heart failure. Well, I don't agree.
What would you say is the mistake that most textbooks make when they're presenting their chapters?
Oh, really straightforward. First of all, it's not clinical. So go to Robbins. How much lab data is there? Right? Testing teaches pathophysiology. So any quotes pathology book that's for a doctor that's seeing patients should be mostly lab data and imaging, because that's how we think of it. Go take a look at Robbins. You can see it's not designed for clinical doctors. It's designed for first-year pathology residents. Well, medical students, that's not a good idea. The second thing is everything isn't equally important. So how many ovarian tumors are you going to teach? There's a lot, dozens. I teach 4.
And does it have to do with how common they are?
No, you got to ask, if I was caring for a patient as a primary care physician, so primary care, family doctor, pediatrician, internist, surgeon, what would I need to know? Well, let's just take testicular tumors. I mean, there's a gazillion. I would say this is what you need to know about testicular tumors. A 30-year-old male presents with a painless scrotal mass. Here's what you have to know. Hey, if you put a flashlight behind it, would it transilluminate or not? It's just a basic idea, cystic solid. Cystic most likely benign, solid most likely malignant. Because after that, what would you do next with your patient is you would refer the patient to a urologist who would then do a radical orchiectomy, give the mass to a pathologist, and she would give you a diagnosis. So why would a primary care need to know all the variants of testicular neoplasms? Well, they don't. That said, are there some principles we can learn from it? Well, there actually is a really kind of a fun principle you can learn, which is, remember, a tissue can produce a protein specific to that tissue. So that means you can follow the protein instead of the tissue. So, for example, if you have a nice variant of testicular germ cells called choriocarcinoma, it produces the placental protein of beta-HCG. So you can actually follow the choriocarcinomas with beta-HCG. Well, I'm not actually teaching you choriocarcinomas. I'm teaching you the concept that if you can find a tumor-specific protein, prostate and prostatic-specific antigen, then that's a nice principle. I don't expect you to know what a choriocarcinoma looks like. That's what pathologists do. So it really makes the book hard for people that are following first aid, because I'm not going to do it, okay? I'm not. Don't do that. So make it clinical. Everything isn't equally important. Teach how to think about. Because what we're talking about is how is the book set up? And understand, for the student and also for that student's teacher, the book is set up for you to learn medicine. It's not a textbook. It's my teaching notes, which I've written down because I got tired of repeating them. So now let's take a look at every chapter is actually different. That's what makes medicine hard. You can't regularly present each system the same way. Here's an example. I was thinking about that this morning. If we were going to teach, we've done heart. So first chapter, clinical pathologic correlation. There are 5 presenting symptoms of heart. You got to hear it right. Shortness of breath, edema, chest pain, syncope, palpitations. That's it. So we start and we talk about what do each of those mean. We then go to structure function. Fine. But then we get into the specific areas. So let's say, for example, I was going to do congenital heart disease. You understand, that's an entire pediatric specialty. Books this thick. Great. But what does a medical student need to know? They need to know 2 images. They've got to know septation, and they've got to know fetal circulation. And if you can do that, you can do 5 diseases, because 5 diseases are 80% of all congenital heart disease. And you know what I do? I present the 5 in a table. So the whole chapter is like 2.5 pages.
We do have a video on how to read tables.
Yeah, so let's just remind them. You take the left headings, you take the top headings, and you have to fill in the blanks. And you come to that table and it's really clinical. So it says, what is the pathophys? How does that present when the baby's delivered? What's going to happen to the baby? Right? And so it forces you to have a clinical approach to the 5 congenital heart diseases that are 80%. You know what I do with the rest? Don't care.
Good. Dr. Tisdall, do you have any other like tips or tricks in terms of when you're going through a chapter?
Don't feel you're going to standardize how you should approach each system. That's why you can't teach yourself medicine, right? Everything isn't equally important, and different systems require different approaches. So when you approach the GI tract, how do you think about the GI tract? It's actually it's a tube with a series of specialized segments. So when you say, how should I think about the GI tract? You start with the overarching principle. I have to gain all of my nutrition, and you think of that as proteins, carbohydrates, lipids. So you should be able to start with a milkshake and have a good defecation at the end. Walk me through what each segment does. And here's a great question. So how does the body create a segment? You know how many medical students have ever answered that? None.
Zero.
Because the answer is sphincters. Right?
Oh.
It's not a hard question. It's how do you think about? So what do you think? Do you think the resting state of sphincters is relaxed or contracted?
Contracted.
Yes. So then do you think, what is the resting state of a skeletal muscle?
Relax.
Yeah. So do you think they're designed totally differently? One is in a perpetual state of contraction that periodically relaxes. The other is in a state of relaxation unless you want to burn the energy to contract. Do you think they have different designs?
Yes.
So you wouldn't think of them the same way. Until someone points that out, it doesn't stick. It's just memorizing more facts about muscles.
And that's really what I think your textbook does well, is that it points out things that stick.
Right. How to think about. So that's why 80% works, because once you've mastered 80% the right way, you can easily fill in the 20% because you know, oh, I really do want to know this ovarian tumor. Great. You know how to think about ovarian tumors. So how do I approach the book? First of all, go to your systems. First of all, every system, every organ, what are the presenting symptoms? Then you say, great, how do I make my structure function right clinically? And then you say, so what are the topics I got to know? Yeah, pretty sure lung's going to have pneumonias. Does it have every pneumonia?
No.
No! You need to know 5. Are there 50? Absolutely there are 50. Why don't I teach the other 45? Teach yourself. If you understand how to think about pneumonias, and you've done the 5 that define 80% of the pneumonias, then when you get some weird thing, you go, I get it. I get how it fits into the idea of pneumonias. Right? So this is surprisingly helpful for everyone. Because most of us that have come through a practical system, we know it because we know it. Right? After you see 10 of something, you just sort of know it and do it. Doesn't mean you really have a way of understanding it. And the reason they pass their exams is they can't flunk everyone. So, once you have a certain minimum passing score, you don't think about it a lot anymore. Every system, start with the symptoms. So when I say joints, can you talk about what are the presenting systems of joint disease? Because you know what no one can do? Sometimes they present with the cytokines and it's systemic malaise. That can precede the painful joint. So it's very helpful. Then you go get the structure function right. I guarantee you'll learn something when you do that. And then you say, what are the groupings or diseases I have to know?
Well, this follower did have a follow-up question. Question number 2. He says, I love your method of learning, starting from chief complaint and differential. However, it's not clear to me how to apply it to learning a particular disease from scratch. Can you elaborate on that?
Oh, well, that's the guts, right? At the end of the day, I don't believe you can teach yourself medicine without having intense small group tutoring. At the end of the day, I want you to go read the book, but before you do that, I want you to have me walk you through it. How do you think about? Just a quick overview. Now you go learn it, and once you think you've learned it, let's talk. So he wants to know, how do you learn disease? Well, that's actually not the right question. The right question is, first of all, with that disease, who walks in the door? What's the chief complaint before I ever get to a disease? So once you've done your chief complaint, then you come to the single proof that you understand medicine. You know how to do a differential diagnosis. And you can't believe how challenging that is. You think you can do it, and you come and we talk, and you realize, no, I only got halfway there. So let's just do an example. Let's just say I had shortness of breath. The medical student's first approach is they mimic what they think they see their skilled people doing, which is they guess a diagnosis. Yeah, what they didn't understand was when you have someone who's really experienced, they've internalized all these decision trees so fast, they didn't even know they were doing it. So it looks like they're pulling a rabbit out of the hat, but that's not you. You're not a magician, right? So when I say chief complaint, this is what I have to teach you. The differential diagnosis starts with, which organs could that be? So and it's 80-20. Don't want to hear that you can have shortness of breath because you had unexpected anemia. Yes, I know that. Don't care. When I say organs, it's 80-20, and it's heart, lung. Notice we didn't guess a diagnosis, did we? We said, what organ systems could give you shortness of breath? Then the next thing, and this is where pathophys just is irreplaceable. Then we say, so which families could give me shortness of breath? And now it's heart, it's left ventricular congestive heart failure, because that's pulmonary edema. So if you haven't got the pathophys picture of heart failure, this is really difficult. When I say, what could it be in lung? You go, well, how do you think about the pathophys of lung? Obstructive, restrictive. If you haven't got that, you just got a shotgun, you're shooting 1,000 pellets, and you hope one of them is the right pellet. It's really not a good way to do it. But understand, even when I say left ventricular congestive heart failure, now you have to kick into that pathophysiology. So now we say, how do you think about that? And now we say, well, 80% of congestive heart failure is ischemic valves hypertension. Well, guess what we just started? 3 new pathophysiologies. When I say ischemic heart disease, can you do aorta, muscular artery, arterial? Can you do that? Because each of those is its own pathophys and differential, isn't it? And it's only after we do that that you can say, no, I now have a diagnosis. I have calcific aortic stenosis as the cause of my congestive heart failure, shortness of breath. And now we can start your student's question. Now that I have a specific diagnosis, now we say presentation, pathophysiology, natural history.
Yes, which we also have a whole video on as well.
Oh, I'm not kidding. That you've got to have the discipline. What everyone fails to do, everyone intuitively understands that presentation. Who could disagree with that? Here's the 2 things the students don't emphasize enough. The first is pathophysiology. You have to have in your brain this instant, essential way of seeing it. It's got to be fast and work well. It's not this long, laborious way of doing things. And the second is, remember, natural history is talking to your patient. So everyone's always great. I got to the diagnosis, but that's not what they ask you. They ask, how are you going to discuss this with your patient? That's natural history.
Would you say it's normal for students to feel uncomfortable learning this way at first?
It is really uncomfortable, and it's uncomfortable for a number of reasons. The first is it's really hard. So when I tell you, you're 10 pounds overweight and you don't feel well, let's get you in shape, everyone knows perfectly well it's going to really hurt. Well, learning hurts. It does. It physically hurts your brain, and it's embarrassing. So when I say to you shortness of breath, which organs, I do this. That's how I start every class of 150 kids I'm doing exam before I walk in and go, so 78-year-old guy comes in, he's got 3 months of shortness of breath, go. And these 150 people, who are all highly anxious, of course, they look at me and I can see it in their eyes. So I've spent 2 years studying my guts out, and you've asked a perfectly fair question, and I got nothing. You just feel like a total idiot and a little bit of resentment and a spoonful of anxiety. So it's a very negative feeling. And the third time I come around and say, no, pulmonary edema, why don't you walk me through why it's a transudate? You feel like a moron. But the truth is, it takes 10 times. Medical students aren't expected to know anything.
That's right. I think if they really accept that principle and recognize that like all of the students around them are going through the exact same thing, and we watch your students go from I'm so uncomfortable, dead silence, crickets in the room when you're lecturing, all the way through to watching them teach these concepts to their peers.
Correct.
And then their scores going up. I mean, it's really
Correct.
quite phenomenal if you can get over that discomfort.
But remember, learning hurts, knowing
Learning.
is fun.
Yes. Yes, it is. And next time we do a Dr. Tisdall Unfiltered, I think we should discuss anxiety and stress. I know
Yeah.
you had brought that up as a common issue that students have to face. And
More than an issue, it is the number one barrier to learning. So when you come to this book, your number one barrier to learning is you're uncomfortable because no one else is doing it, and everyone else is doing first aid and some multiple choice question bank. And I'm telling you, don't. Well, that's a really big swallow, isn't it? So
yes,
I
it is.
never win the students over until about the fourth or fifth time, and they go to their multiple choice question bank and they go, oh, this makes perfect sense. It wasn't just, can I find the magic word that lets me link to an answer? No, it's a conversation.
Yes, it is. You've mentioned a couple things in this podcast. One is how important it is to do these, to come back and test your thinking with me
Oh,
or with a teacher. So just to give you guys an update, we are actively working on 2.0 of our community. We do have a ton of resources at our Med School Companion website currently, but the 2.0 is going to be very much like it's based off of sort of the Circle app where you can come in, join them as a member, and you will actually get access to Dr. Tisdall through lives, through discussion boards, everything like that. We do have an existing question bank. The question bank will be in the new feature in the new app as well. So stay tuned. We're building it out, and be sure to subscribe to make sure that you are staying up to date with that. And Dr. Tisdall, any final words of wisdom?
well, I was actually going to tell them what it's like to study and then come and talk. Do we have
Yes,
time for that?
absolutely.
Okay. So I'm working remotely with a medical school across the country from where I live. But the students know I'm at my desk all day. And so they literally can ping me with a question. Hey, just a quick update. Have I got this right? And most of the time, the question is so bizarre, I can't imagine why they would ask the question. And so I will send back going, this should be discussed. And so the other day, this school studies in pods, and one of the students said, hey, have I got this right? And I went, we have to talk. Now? Sure, right now. So we literally video linked, and he was there with his study group. There were 5 of them. And what started as a little innocent question about antibodies exposed that they had no understanding at all about autoimmune diseases. And so we spent 50 minutes just saying, let's talk about how we think about the hypersensitivities, because they really just had it wrong. 50 minutes later, every one of them understood it perfectly and will always understand it perfectly. But, they were studying facts. They just wanted to check a fact. They didn't realize the whole way you see that fact is because you don't have a concept of why you need it. So there's no way to teach yourself that. And that's what we're going to be doing in our community, right? I'm going to be coming on live at predictable times. And sometimes I'll talk about things I want to talk about. Sometimes I'll open up and say, so what's everyone learning? Let's talk about something. And we'll start in one place and we'll end up talking about, well, what's the difference between IgG, IgE, and IgM? Wow. Okay. Well, that matters.
Definitely post your questions in the comments section because we do answer them. We read every single one. We discuss which ones we should talk about in each Dr. Tisdall Unfiltered episode.
I mean, clearly I'm a teaching fool. I mean, I'm such a
Yes.
sad, pathetic, lonely old man that when someone asks a question, I go, well, that needs to be fixed. I mean, oh my God,
Yes.
IGM isn't IgG. And I really enjoy it, right? When you say, hey, why aren't you out windsurfing more? The answer is, I could do that.
Yep.
But first, I'm going to get down to what did you think a granuloma was?
Well, if you guys liked this conversation, be sure to check out our most recent podcast where we discussed some of the questions that you guys had posted about how to learn anatomy. That was one of the questions, as well as how problem based learning works in medical school and how that compares to your method of teaching, Dr. Tisdall. Thank you for watching, and we will see you next time.